Welcome to a Shot in the Arm podcast. I'm your host, Ben Plumley, and this is the podcast about innovation and equity in global health because, let's face it, without equity, what on earth is the point of innovation? Well, we're back to HIV, and HIV as a forerunner for other infectious diseases, but also how we manage our relationships between doctors, patients, and laboratories, and the whole complex system within the healthcare. So, how's this for a riddle? Someone described by his or her physician living with HIV, suddenly out of nowhere on highly active antiretroviral therapy, gets a higher level of virus in the bloodstream than they previously had. What is this? Is the patient unwell? Is it just a one-off? Is it made worse by the more increasingly sensitive viral load tests that monitor something quite different perhaps going on in the body than whether the antiretroviral is combating the virus? Is it a question of the science or how the health professionals communicate the science to their patients? Well, I'm delighted to say that I'm joined by friend of the pod, Professor Ben LaBrot, Professor of Global Medicine at the Keck School of Medicine at the University of Southern California. And of course, he's the medical affairs lead for Roche Molecular Diagnostics. Ben, great to have you back on the pod.
Thank you so much. Always a pleasure.
Now, I've got to ask, did I get the positioning of that question right, or right enough to get going?
I think so. It's this question of, what happens when you're undetectable and undetectable and undetectable, and then suddenly you open your MyChart or something like that and see detectable, but it's only 20 copies. What does that mean? How do you react to that? And how should clinicians and labs respond to that?
Yeah, and that's the bulk of this podcast discussion. We are also joined, and I'm really delighted to say this, we are joined by Daniel Griffin, who is the Chief of Infectious Disease at ProHealth. He's a clinical instructor of medicine at Columbia University, but perhaps most importantly, he is a fellow podcaster. He's the host of the renowned This Week in Virology. And Dan, I got to say, I bow to you. Over 1,000, 2,000 episodes. It's a real honor to have you on our podcast.
Oh, thank you. Thank you so much. I will have to correct a few of those affiliations. It keeps changing, right? I can barely keep track of it. So it's now the chief for infectious ID. But no, as you point out, I was the head of ID for ProHealth. I was the senior ID fellow for United Health Group during the pandemic. I was the head for Optum Tri-State, covering millions of patients and thousands of doctors during the pandemic. But I cut my teeth on HIV, and my academic position is at Columbia, where when I would agree to come out of my lab doing HIV research, it was to see HIV patients.
And do you still see patients? Is this
yes,
still
I do. Oh my gosh. Some of my colleagues think, I have this fear of missing out, Ben. If I take a day off, what if an exciting case were to come in the door? So I might often go stretches of 20 days in a row without a day off until my colleagues say, Dad, you should spend a little time with that family. I say, oh my gosh, yes.
Oh, yes, I've got one of those. Yes. Well, it's really terrific to have you on the show. And I know the pair of you have worked closely together over the years. And I wonder if you might just sort of set the stage of it for us. Why are you both so interested in this specific laboratory phenomenon, the viral blip? Why is it important? Or perhaps, why is it more important to explain it to the patient than it is as perhaps a clinical finding?
So the reason this sort of came to top of mind for me this year was in my role as Roche's medical affairs, kind of global lead for molecular HIV diagnostics. I often get pulled into calls with customers who are having difficulty or having questions about the use of, kind of our assays in their lab. And I felt like this calendar year, I participated in more support calls for laboratories that were concerned about increasing frequency of blips in their results than I have been in my entire, the rest of my 5 years at Roche, just this calendar year. And I'm not really sure why it seems to have spiraled up so much, but the pattern is always the same. The labs, so we've seen an increase in the kind of detectable versus non-detectable patients. We're wondering if there's a problem with the instrument. It's almost always related to like pre-analytics or some other factor in the lab. But once you start looking at the actual levels, when I go, okay, well, detectable at what level? They'll say something like, there are these 10 results, viral load of 32, viral load of 18, viral load of 27. And I kind of look at that and go, well, these are probably of very doubtful clinical significance. Yeah, we've sort of become victims of our own success by creating assays that have limits of detection down to, a dozen copies. You don't have a lot of wiggle room for the natural variation. You could test the same sample 12 times. And it might be 10 once, it might be 12 the next time, it might be 9 the next time, it might be 11 the next time. But if your if your LOD is so low, you can easily fluctuate back and forth across that detectable, undetectable line. And so this got us really thinking about, well, what does undetectable mean? We talked a lot in the HIV world about U equals U, right? Undetectable versus untransmissible. But what does undetectable mean? And this is where the confusion comes in. World Health Organization took the position that under 1,000 is essentially functionally untransmissible. Pharma tends to use...
Functionally suppressed, I think, was the wonderful UN phrase they came up with.
And they were correct. Like under 1,000, you'd be very unlikely to transmit this to somebody else. So I was actually in Australia at AIDS when they made that announcement, and the cheers that erupted. It hadn't occurred to me, really, it should have, but it hadn't until I was there, what a huge impact that really had for people living with HIV. But, you've got pharma using 50 copies as undetectable in most of their trials. But then you've got clinically defining undetectable as below 200 copies, which is the most clinically relevant cutoff. And then you've got whatever the LOD is of the assay, which in practice is what a lot of clinicians and patients certainly use for undetectable, whatever the LOD is of the assay. And now that we have assays down to a dozen copies or less, the likelihood that someone who is totally well suppressed at 9 copies and whose next test might be 13 copies and is suddenly detectable is really high. So you've got a patient opening their MyChart or whatever, and then all of a sudden they're expecting to be suppressed. They're expecting to be undetectable for months on end, and then suddenly detectable, and there's a viral load listed. And it seems that the knowledge and understanding of this, both among patients and especially among non-specialist clinicians, like the primary care physicians that are increasingly getting involved in both HIV management and PrEP, really are not that aware of this phenomenon or how to approach it when it occurs.
Well, just before coming to you, Dan, Ben, can you just explain what LOD is?
So the limit of detection for an assay. So the lower limit, the lowest possible viral load that your assay could reliably detect.
So Dan, now I've got you. I was heavily involved in the U equals U debates from the community perspective those few years ago, and what an utter transformation, community-led transformation it was. But here was the problem that I think so many people encountered, in that people didn't really understand what undetectable meant. Did it mean that I'm functionally cured, that I really, to all intents and purposes, have no HIV, and that the medication, as long as I take it for life, acts as, if you like, as a therapeutic vaccine? Or is something else going on? How do you explain it to your patients?
Yeah. So, it's going to be interesting, like different people, different audience members, whether you're a physician, you're primary care, you're the HIV specialist, you're the patient listening to this. I think it's important to understand where this conversation fits in. And Ben and I, it was a while ago, we started talking, what do we think is a really critical thing to talk about? And this is Ben, this whole concept, because there's been several milestones in our understanding and treatment of HIV. And I grew up in Greenwich Village, early 1980s. I saw 90% of our neighborhood die in a matter of years. Devastating. Initially we didn't even know what it was. There wasn't even a diagnostic test. Then we get a diagnostic test. Then they've got all these different potential therapies. It wasn't really until the 1990s, mid-90s, that we finally actually, put together cocktails, highly active antiretrovirals, started to turn the tide. You weren't going to just die. We weren't just slowing that. You could potentially actually start living for quite a while, but without having sex, because there was still this stigma. And so it was really huge when we got to this point, and we have to be a little careful, because catchy phrases are catchy phrases that always capture the whole truth. Undetectable is untransmittable. Well, that's great and all, but now you pharma guys make these sensitive assays and I'm detecting it, and you still stay in that thing. And it's not so catchy to say under 1,000 is untransmittable. Under 500 is untransmittable, right? I mean, they're just not catchy. And because they're not catchy, we've created all this confusion. And I think that's probably the big thing we need to get across here. And we'll talk a little bit about what's going on. But we say viral load, and we let you guys get away with saying viral load, Ben. I'm talking to Ben LaBrot here, but it's really not. This is a PCR. You're picking up nucleic acid. You're not necessarily. I mean, probably 999 of those in every 1,000 are not functional, replication competent, infectious viruses. So that actually helps to make sense. When you say, oh my gosh, look at this in this microliter, there's 800 what? 800 amplified units. Maybe there's 1 or 2 replication competent viruses in there. And we know that when you get down to these levels, you're not transmitting. We're going to talk a little bit about why is this even happening when you're on highly effective therapy. It seems to be working. The HIV specialist isn't concerned. But I think that's the first thing. We just have to really address the first question is, at what level do I have to worry that I'm going to spread to my partner? At what level do I have to worry that I'm a danger to others? And the WHO is just saying it's 1,000. And all the studies we did initially, they were at 500. And then we realized, 1,000's fine too. That is the level. So below 1,000, you're not transmittable. It's not a quick, easy, memorable thing. But what happens when you are going along and you have, a level that's less than 40, less than 20, the assay is saying it's undetectable. And now you get a number. And we'll talk a little bit about that. And one of the big problems now, right, is that we as clinicians are not the first ones seeing those results. The patient looks at MyChart on a Friday night, right? Friday night, 5:30, they look at MyChart, they're kind of waiting to go out, they're done with their busy work week, and they see, oh my gosh, I'm now detectable. I have a value of 350, and they panic. And so, so maybe I'll sort of let you guys jump back in after that.
I mean, a deep breath taken there, because the idea of yourself as a patient finding a sudden rise, and 350 is substantively different from 5 or 15. And even if you're up to 700, and the WHO would still say that you're functionally suppressed, it seems to me that there is a lot of information without the absence of context, and that is what makes making sense of this information, if you are a patient, a real challenge. But Ben, how would you respond to what Dan just said?
I really thought I tried to put myself in the position of potentially living with HIV and being undetectable. Let's just say, for argument's sake, undetectable as per my MyChart, for years on end, and then all of a sudden opening it and seeing detectable, and either 75 copies or, to Daniel's point, 350 copies. Knowing everything that I know now, I'm pretty certain that I would still not be able to avoid a little twinge of anxiety, that would probably not be alleviated until I had a repeat test a couple weeks later that showed, nope, you're not in treatment failure. There would be a tiny voice in the back of my head going, oh God, this is how it ends. even knowing what I know now. So I can only imagine people who've never even heard the word blip, kind of opening it and seeing this, and kind of what kind of anxiety, and kind of stress that really could engender. I do know one of the big reference labs has a couple of years ago started adding reporting language to those results that say something along the lines of, if it's detectable, there's a detectable below 200 is not necessarily indicative of treatment failure and warrants a follow-up conversation with your clinic, something along those lines. And they said that actually noticeably and almost immediately decreased the number of calls the lab was getting from physicians, who were of course getting calls from patients, that it really had settled. So there's definitely a knowledge gap here, that needs to be filled. There's an unnecessary amount of stress and anxiety, going on here that could be alleviated, I think, if people had access to the right information.
But again, you're using, I don't know, the app on your cell phone or whatever it is to find your viral load. Do you worry that perhaps the technology, both the viral load technology and indeed the communication technology, has surpassed our ability to communicate, contextualize with patients? And on a Friday night or a Saturday morning, the last thing a local infectious disease doctor is going to want to do is be answering a whole load of calls from the worried well. But is there some way, do you think, in which the technology, the information, as you were describing, Ben, put a health warning on it, but some way of being more attuned to the contextualization of this? And maybe that comes much, much earlier on in the doctor-patient relationship, Dan.
Yeah, I was going to say, I mean, Ben points out a thing, like we're going to talk about like sort of prebunking the fear and explaining ahead of time, like, prepping your patient. Hey, by the way, and not prepping with, your pre-exposure prophylaxis. This is after. This is, you've got HIV, we're monitoring you. But explaining, like, listen, we're going to go along and, great, non-detected, this is great, we're doing fine. But sort of letting them know, hey, by the way, there will be times and you're going to get a positive number. It's below 1,000. We're not worried about transmitting to others. Below 1,000, particularly below 200, we're not going to worry about it. There might be times we want to repeat it, but this is to be expected. So don't check your viral load on Friday night, because we're not going to be able to talk about it. And maybe what we're going to be doing in the next little bit here is talking about why this happens and why it isn't the end of the world, why this isn't, foreboding, why this isn't necessarily, oh my gosh, if it's 350 today, it'll be 700, 1,400, 2,800. It does not necessarily signal that.
Well, let's do that. Let's try and demystify, if you like, what the blip is. And I don't know which of you would like to take this first, but I'm starting therapy. Dan, you're saying to me that, we hope to get you to undetectable. You might see some blips. How do you go about telling someone like me that the blips are nothing to worry about, or they may not be nothing to worry about, assuming we regularly retest you?
Yeah, I'll go first, because then Ben's going to have to find the more esoteric explanations, right? But no, the first conversation, I have is explaining about the process, right? You got infected. HIV establishes these reservoirs, so it's in your body. This part of this conversation is explaining to the patient why you're going to need to stay on this medicine. This isn't a medicine that's going to wipe HIV out of your body. It's going to be in a lot of your cells. A lot of the cells are going to be your T cells. These are cells that are out there fighting other infections. And so we get you on this highly effective therapy. Your numbers come down. You're doing great. All this inflammation is settled down. Your immune system is coming back. You're no longer at risk of these horrible infections you may have heard about. Not just may, because everyone's on social media. I'm sure you've heard about them. But we're going to get those things for you not to worry about. But the HIV, it's still in a lot of these cells. So when those cells are, let's say they're fighting another infection, they get activated, some of the nucleic material might spill out. We might pick that up in a blood test. That doesn't mean that your HIV is replicating. It doesn't mean you're a danger to others. But at some point in your life, your cells with HIV in them are going to get activated. We're going to detect that in the blood. So if you check it on, hopefully you're not going to check it on a Friday night, but you're going to do it anyway because sometimes people don't listen to me. Imagine that. And you're going to see this number and then ask yourself, boy, in the last week, have I had like a sore throat? Have I had a runny nose? Have I fought anything off? Probably can come up with the explanation yourself right there.
That is actually one of the things when we're talking to labs. A bad flu season in an area can increase the frequency of blips that a laboratory is seeing, because as Daniel pointed out, people who are busy fighting off other infections, you can get spillage of the nucleic acids. Do you know what I really liked about what you said though, Daniel? Because I talked to a number of my friends who are living with HIV and I asked them, first of all, not one of them had actually heard of blips ever. They didn't even know the term, which is another reason I was like, okay, so there's this is a real gap that we have to address here. But none of them had that kind of initial conversation with even the ones who had a doctor who was apparently taking good care of them, they trusted, had a good long-term relationship with. They had not had that specific conversation. And as Ben pointed out, this is sort of a technology-driven problem. The patient access to stuff electronically instead of getting it directly from the doctor, the results. The increasingly, kind of low, kind of limit of detection of our assays and things. We become victims of our own success technologically. And some of the solutions could be technological, such as the reference lab, you're indicating reporting language. But I really agree that this is a technological problem best solved with an analog solution through the relationship of the doctor and the patient. And your idea of that initial conversation, go, hey, every once in a while, you might open it up and find that you're detectable. Don't panic. Like a very small percentage of those, are actually treatment failure. Mostly they're just blips that can occur for a variety of reasons. I think that that's brilliant. And there are a really wide variety of reasons. The lab, a hospital that's collecting the samples could have installed a pneumatic tube transport system that shakes up the samples. Just that can do it. Here's another one. A lab could be using a reagent lot that is performing well within the range of specified performance, and then they could switch to another reagent lot, which is still performing well within that range. But within that range, because our limits of detection now are so low, you can have two lots of reagents that are both performing just fine, but you test the same sample, and once you'll get a level, a viral load of 9, and once you'll get a viral load of 22. One is detectable, one is not. Is that relevant in any way for the patient's health? Not at all. But you can see how sensitive these systems are to the tiniest little things that can shift the needle a few copies or a few dozen copies either way so easily.
There's something that you've both said that intrigues me. So I'm going to ask a stupid question and see how far off I am. But particularly with these very, very low viral loads seeing blips, it may not be the virus that is being picked up, but bits of dysfunctional chains or part of the virus, and they flag up in viral loads in exactly the same way that a fully competent and armed HIV would. Am I understanding that right? And if so, does that sort of change the nature of the conversation with patients at that level of detection?
I think it can. I do think this is one of those things that a lot of clinicians are not really aware of, right? I joke, we let you guys keep saying viral load, right? But, when you did that during COVID times, we kept really sort of saying, really, positive PCR, positive antigen test. That just means the virus might be destroyed. You're just picking up skeletons and bones and so, it's important and it's true. And one of the proof of the pudding is when you say, oh, well, I'm a little worried here. Let's send this off for sequencing. And you're like, oh, we can't really get sequence when it's below 1,000. Well, why? Because it's all junk. Like you actually really probably don't have much, if any, actual virus in there when you're just picking up, RNA fragments. And so I think that also helps, when you talk to the patients. It's like, yeah, there's a bunch of that HIV RNA and a bunch of junk, and even when we shut down the virus, even when it's not replicating, you still might pick up some of that junk when it gets spilled out.
I mean, you imagine you take a sample of whole blood. You only want to test the plasma. So you put the whole blood in a centrifuge and you spin it and spin it and spin it until all the whole blood products, the red blood cells, the white blood cells, plates, all sink down to the very bottom. Then you test just the plasma. And the reason that's so important is because you will have integrated HIV DNA, called proviral DNA, like in some of your own cells. And if you end up accidentally measuring that proviral integrated DNA, that will artificially and incorrectly increase your viral load. I'll use the air quotes for viral load because in this podcast, saying viral load makes even the least sense, right? Yeah. In fact, this is at these very low sensitivities, or I should say very high sensitivities, at these very, very low levels, that effect can be so profound that just, once you've spun that down, just the act of carrying the tube across the room might jostle it just enough for some of the proviral DNA that's been spun down to the bottom to get kicked back up into the plasma. And so much so that many labs that sometimes run into this problem find that adding a second centrifugation step right before running it actually substantially improves their results. I mean, this is how sensitive these systems are to these little tiny things at these levels. I have seen a couple of papers or editorial pieces where people had suggested, it might be that we shouldn't even report anything less than 200 copies. Yeah, but most clinicians that I spoke to would prefer, to, still know the level, even if it's below 200 copies. I think I would as well. But that is also an indication of how much of an issue this is, that there are people saying, look, we can detect down to 10 copies, but I don't think we should report any viral load that's less than 200 because of these kinds of challenges that can occur.
Well, that would make sense, particularly if, as Daniel said, much of the material you're finding is bones and skeletons of the stuff. Is there research on the horizon, Ben, that will help us clear out some of this garbage, some of this noise, so that we are, truly finding the HIV Trojans that could cause damage? Or are we back to the position of having to explain things much more carefully to our patients?
We actually did an advisory board towards the end of this last year to kind of explore this. It was a really global board. We brought together experts, from every world region. And the consensus was essentially, you don't really need to do, anything with your assays. They work very well. They were like, if you find a way to increase the precision at the lower end of your assays, great. But we recognize the laws of physics, you start really running up against the laws of physics. Yeah. In terms of how much improvement beyond the ridiculously sensitive tests we have now, you could really get. They said really it's the landscape that needs to alter. The landscape that these tests are being used in needs to alter to reflect the kind of reality of testing with assays that are actually this sensitive.
And I want to come back to the question of the landscape in a minute, but Daniel, could we sort of perhaps talk about clinical management and what you do, why results fluctuate, why one of your patients gets a blip and you foolishly answer your phone at 9:15 on a Friday night? How does that work? What do you tell them?
Yeah, so remember, I have fear of missing out, so my phone is always right here, ready to go, because oh my gosh, you guys keep watching that Netflix show because this is much more interesting, and it is. I mean, these are great conversations, and I mean, the one side, it's upsetting that the patient has to deal with that fear and the unknown and the questions, but these are some of the reasons why a lot of us went into medicine, to be there to explain. So it's not bad that we're having these conversations. Ideally, as we talked about, we're having them ahead of time. The patient is prepared for them. But you're going to have them again anyway, because who knows how well they were listening until they got that 350. Now that they get 350, they're like, yeah, I know you talked about this, but actually now I'm going to pay attention, doctor. And so now is when you have that conversation, and you can go back through what we talked about before, and explaining, here, this is what's going on. We talked about this a little before. Maybe this is ringing some bells. And I think that's going to happen in our modern world. We're going to have to realize that patients have access to their results. They have access to those results, and they're checking before we check them, before we see them. So, this has changed practice. You have to be ready in those conversations with your patients when you order tests to be prepared for them to get those tests, and you've got to prep them for what to do when they get those.
I'm living and breathing that at the moment. It's not directly relevant to this conversation, but I have stage 4 colorectal cancer, and I'm having a battery of tests also delivered to me down on an orange iPhone, and
you could buy the cheap one and get an orange case.
Yeah,
but anyway, just let you know.
But the thing that was actually a sort of fatally funny about it was that my oncologist said, well, yeah, if you do a test and you don't get a result coming in the next, hour or 2 hours or end of the day, yeah, we'll probably hold off if there's some stuff in there that's alarming, and we'll meet with you and talk to you. And like, oh my God, so part of my wellness is knowing that I get the result. If I don't get a result, so it's...
Yeah. No, and a lot of our patients have become educated, right? So we've taught them, and I think it's important to teach them, to this higher level, taught them that, okay, there's 2 big numbers that we're going to worry about. We're going to worry about your T cell numbers, and maybe we'll even get sophisticated to talk about percentages as opposed to absolute numbers, because the percentages are more steady. Absolute numbers are going to fluctuate. So very sort of similar to what we're talking about here. Like, oh, wait, what happened to my T cell count? It went down. But was the percent stable, right? So you prep them there. And then you talk about the viral load. You say, all right, the viral load, we've now got you down below 1,000. That's great. And it's nice to sort of word it that way. It's non-detectable. It's under 1,000. We're talking about under 1,000 here. It might bounce around, and we talk a little bit about why, and they don't listen until it does. And then we have that conversation again. And that's one of the things about HIV care is it tends to be longitudinal. It isn't one and done. You're not showing up with a urinary tract infection and then going on to the next urgent care in 6 months when you have another problem. This is a relationship. And if you keep building that relationship, if you keep being there for the patient, if you keep answering those questions, if you keep preempting so they're ready for whatever results are going to come that way, that's going to build that relationship. And then that person is going to be more likely to take their medicines, more likely to do well.
Now, that sort of spidey sense that you both have, that where, is this just a blip, or is there something else going on? What sets that off in your mind? What perhaps makes you think we may have this test, but we should be looking more into it?
Ben, I'll let you jump in.
I guess from my end, certainly, I've talked so far about like laboratory and kind of situational factors that can cause this, but there are patient factors. What if they've had pretty bad diarrhea for a few days? They may not have absorbed their HIV meds effectively, so they, it's sort of an involuntary non-adherence issue. Or sometimes people, there are people who forget, take their pills. Now, this is where, to Daniel's point, this longitudinal relationship, I'm going to guess that after like 5 or 10 years of managing an HIV patient, having that relationship, you probably have a pretty good sense of what their adherence is like, what their compliance is like, if there are any potential vulnerabilities that patient may have to a blip, or treatment failure occurring compared to some of your other patients. And so I would say that clinical suspicion, but clinical suspicion not necessarily based on clinical signs and symptoms, clinical suspicion based on your longitudinal knowledge of that patient because of your long-term relationship with that patient is, I would guess that that's probably going to be the strongest factor to help you intuit whether this is, I'm 99.9% sure this is just a blip, the next one, or this, I wonder if this could be related to some kind of adherence or treatment failure issue, whether transient or long term.
Yeah, I mean, there's science here, right? So, you ask that question like, hey, how many times in the last week or the last month have you forgotten your meds? That non-judgmental, because if you don't actually get, we'll say the most important and least reliable is the history. So you want to sort of get that. If the person's like, oh, I had some issues and I haven't been on my meds for a few weeks, okay, you can start thinking differently. If, as Ben brings up, they've had diarrhea, they've had nausea, they've been sick, they were really knocked down with something, you can get from the history at least some suspicion, is this likely to be a problem or not? And sometimes it even just serves as another sort of reminder when you're asking, like, it's really important that you take your medicines, because if that's the case, then this is probably just a blip. But if you haven't been taking your medicines, if you've been forgetting, then okay, then maybe this won't be just a blip.
Right.
Where the blip could serve as a wake-up call for patients who are maybe struggling a little bit with their adherence.
Yeah.
What a lovely entry, Ben, into the final section, which is, dealing with the landscape, looking at, because I'm struck that you're both very committed to this issue and communicating about it and clarifying it for folks. But it's been around for a few decades, hasn't it, since ART really kicked off? And it's not very well known. So what do you think the solutions are and the advocacy that's needed to help sort of bring this to the right level of attention, both within patient groups and with the clinical community?
I mean, Ben LaBrot and I had this brilliant idea that we could get like a famous podcaster to talk about it. No, I think a lot of it is we just need to get it out in front of there. Just people like, oh yeah, it sounds silly, but no, like, hey, I heard this podcast. They were talking about these viral blips. Apparently, this is what's going on, and now they have a sense. I don't think it takes, it's not rocket science, and I'm sure rocket science is rocket science, but no, this is just we've got to communicate better about this stuff, because now we have, unfortunately, we have, over 1 million people in the United States living with HIV. They all need to understand this. 40, 50,000 new cases each year in the US. They need to know about it. All the people throughout the world, the millions throughout the world living with HIV and all their caregivers. In the US, it's now nurse practitioners, primary care docs, not just HIV specialists. People like Ben and I, we're steeped in this stuff and, at this sort of fundamental molecular level. But this needs to be something that if you're managing, interacting with, or a person yourself with HIV, this is stuff you've got to understand.
I guess like with my, like taking my like clinician hat off and putting my industry hat on, my thought was essentially, looking at what's the best way to get this information out? And we really speculated, and I talked to Mitchell Warren about this, to pick his brain. How do you get information out to the two stakeholder groups that really need it, which is the patients and the clinicians treating them? And there's all kinds of, maybe through the social media apps that people use, you can get messaging out that way. Maybe this is something that pharma might get involved in as well. Who knows? Because after all, like every time people have a worry that a blip is related to treatment failure, that also that indicates a reduced confidence in the treatment itself. So pharma, you would think, would have like a real stake in this as well. And so with my industry hat on, really it was kind of looking at what can industry do to try and support this, get information out to patients and people living with HIV and their caregivers and family and people in their networks and the clinicians who are caring for them, especially this increasing body of non-specialists who are looking after people living with HIV, the nurse practitioners, PAs, NPs, and primary care doctors. So doing things like this, a podcast that has listenership that includes HIV specialists and people living with HIV and people who are just interested in the science. You hope that you can get the information directly to people, but just getting it out there means, someone is like, oh God, they're at dinner. I just checked my results and now it's, my viral load is this, but I've been so adherent. Maybe someone who's heard this podcast and is at that table goes, I heard something about this, And most of the time, that's actually just a blip, and you just need to get retested. And they go, "Oh, really? Okay, I'll go talk to my doctor." Yeah. So I did want to ask if Daniel had any thoughts, though, on anything else industry can do by way of support. I mean, you can do CMEs, we can put out information, we can publish papers, we can publish editorials, we can do podcasts, but really always open to anything we can do to alter this landscape, and make it an easier landscape for people living with HIV to live in.
Yeah, no, I mean, I'm glad you're asking, because as we're realizing, the reason we're having this conversation now is this has been a phenomenon that's been out there, that's been known about, that's impacted treatment for years, but yet the appreciation of it is still pretty low. So whatever we're doing, we haven't done enough. And so, this podcast, though, is going to turn it all around, you say.
Oh, yeah, just like that. But look,
problem solved.
Good start.
There is one thing that you both didn't raise that I think might be worth putting on the table increasingly. And we see this in the US, we see it obviously across Africa, but the role of community health workers. Ben, I'm chair of the San Francisco Community Health Center, which provides 80 to 90% of care for San Francisco's trans population, and a very, very significant amount of care for the homeless population in San Francisco's Tenderloin. People's first exposure, even if they're on treatment, is with the community health worker doing the rounds. And I think there is a real utility there. The same is true in LVCT Health, the clinic I was talking about in Kenya, so true in Uganda, in China. The role of community health workers has expanded, really. And I think you see them as an unutilized tool. And the other thing I'll do with my other board hat on, which is Viva, chair of Sugar Global, which is what the MTV Staying Alive Foundation was, now based truly globally, and as it does its series of TV shows, one of its characters living with HIV could very easily, over a course of a series of episodes, have to deal with this blip. So a lot of things come to mind. I think it's a fully comprehensive approach that we need to take.
I think I might follow up with you offline about that, because I would not mind at all experimenting with some of the community health workers, like in the Tenderloin. I'd love to see what they already know about this, if anything, and fill in any knowledge gaps that they may have, and see. That would be I'm going to follow up with you about that. That would be a really interesting place to start, I think.
Absolutely. And I find myself absolutely humbled by the fact that I know significantly less than they do. But it is interesting that this is not something that ever comes up. But yeah. Well, look, we're coming up to the top of the hour. And I just wonder, Daniel, Ben, what have we missed? What are the important things we need our listeners to know beyond getting their backsides together and acting on this?
Yeah, no, I mean, I think we've talked a little bit about the catchy undetectable is untransmittable, and that's not quite the science, which is you get that under 1,000 and things are good. And those numbers under 1,000, we're not that worried about them. We can explain why those are happening. The sky's not falling. Let's make sure we have these conversations. I think it's a great thing you bring up with these community healthcare workers. And not only do we need to communicate with our patients, but we need to be there for our colleagues when they have questions, so they also understand. Because as a growing number of people are helping to take care of folks with HIV, we need to make sure that the knowledge, the expertise is out there, it's accessible, and it's ultimately benefiting our patients.
And I think what I would add is this is a problem that's not going to go away, even as we make progress, towards HIV elimination. In fact, it might even get bigger, because as Daniel pointed out, we've got, 40, 50,000 new diagnoses every year. And most of those people are living now. They're not dying. Fortunately, this is not the 1980s, where, We're going to keep you as comfortable as possible for as long as possible over the next few weeks, right? Like we're not there anymore. Every time I go to a conference in the past couple of years, there's an increasing percentage of the HIV-related papers related to things like managing hip replacements in HIV patients, dementia, like there are problems of old age that are really great problems for us to be focusing on, because the HIV has become so second. We're so good now at actually managing HIV that everyone's living long enough, most people are living long enough to die from, other things, thank goodness. But that means the body of people living with HIV is going to increase for probably a good few years yet, as we keep having new infections, but everyone is living. And so more and more people are going to be cared for, and more people are going to be getting blips. And so I think there's a real imperative to really push now to try and make this part of the normal everyday knowledge, kind of HIV knowledge package that folks living with HIV and the people who care for them and work with them also have.
Well, Ben, Daniel, thank you so much. That's it for this episode. Thank you to our guests and to the really important conversation of viral blips, which we will be coming back to frequently in our Substack, in our TikToks and our Insta. Let's see if we can really raise the bar around understanding here for people with HIV. A big thanks to Erica Spera, our director and producer of A Shot in the Arm Media. And finally, a big thanks to you. Now, you can find us wherever you download your podcasts, but if you care to, we're looking to build up our subscriptions on YouTube so you can see us and hear us in full Technicolor. And all you need to do is to go to A Shot in the Arm's channel link on YouTube and you'll find us there. With that in mind, hope you all have a great week and a safe week, everyone.